So let me start with clinical case on carbonic anhydrase inhibitor. A patient started taking acetazolamide for mild altitude sickness. What is the mechanism of action of this drug? It acts as a carbonic anhydrase inhibitor, as you know, and it causes sodium bicarbonate, diuresis, and a reduction in total body bicarbonate stores. Now, what is the reason for this? How it helps? What's the rationale? So, in case of hypoxia in high altitude, it causes hyperventilation. So, finally, hypocapnia, alkalosis, and which leads to apnea. So, this acetazolamide it causes bicarbonate diuresis, and that's how it helps in preventing apnea. Now, the second case is a patient with homocystinuria develops a unilateral colic abdominal pain. Why might we be prescribed acetazolamide? So, as you know, acetazolamide it causes alkalinization of urine, and cystine stones are likely to form in alkaline urine. So, uric acid and cystine are relatively insoluble in acidic urine and causes enhanced renal excretion can be achieved by increasing urinary pH, and that's how carbonic anhydrase inhibitors are helpful in such condition. Similarly, renal excretion of weak acid aspirin is also enhanced by acetazolamide. So this you learned already. What are the adverse effects of carbonic anhydrase inhibitors? Now coming to next group of diuretics, highly efficacious drugs. These are loop diuretics. They are called as loop diuretics because their site of action is the ascending loop of Henle. So loop diuretics selectively inhibit sodium chloride reabsorption in the thick ascending loop of Henle. So owing to the large sodium chloride absorptive capacity of this segment, and the diuresis is not limited by acidosis, which is seen with carbonic anhydrase inhibitors. These are highly efficacious agents. So the prototype is furosemide. So this furosemide loop diuretics, they act by inhibiting sodium potassium chloride transporter. That's how sodium reabsorption is prevented. So like carbonic anhydrase inhibitors, furosemide, bumetanide, and or sulfonamide derivatives. So they have carboxyl group with a sulfonyl mitis in the meta portion. In case of sulfonamide allergic patients, care has to be taken. So these are well observed pharmacokinetic features eliminated by renal secretion as well as glomerular filtration. So diuretic response is rapid following intravenous administration. Duration it usually lasts for 2 to 3 hours. Half life it depends on renal function. So furosemide it acts on the luminal side of the tubule. The diuretic response correlate positively with the excretion in urine. So defect in the secretory compound of the clearance may defects in the urinary component of its clearance may result from the simultaneous administration of agents such as indomethacin and probenecid. So, which inhibit weak acid secretion in proximal tubule. That's why non-steroidal anti-inflammatory and drugs they blunt the diuretic effect. Why? What is the reason? Defects in the secretory component of its clearance, which result from simultaneous administration of indomethacin or with probenecid, which compete with the secretion, which inhibit weak acid secretion in the proximal tubule. Okay, that's how concurrent administration should be avoided. Now, pharmacodynamics, these drugs inhibit the coupled sodium potassium 2 chloride transport system in the luminal side of the thick ascending limb of Henle. By inhibiting this transporter, the loop diuretics reduce the reabsorption of sodium chloride and also diminish normal luminal positive potential which derives from potassium recycling. This electrical potential normally drives divalent cation reabsorption in loop. So, loop diuretics, by abolishing the lumen positive potential, cause an increase in magnesium and calcium excretion. So, not only sodium chloride, magnesium and chloride, calcium excretion is also increased. Hence, prolonged use can cause significant hypomagnesemia deficiency in magnesium in some patients, since calcium is actually reabsorbed in distal cannulated tubule. Generally, loop diuretics they do not cause hypocalcemia. However, in disorders that cause hypercalcemia, calcium excretion can be greatly enhanced by combining loop agents with saline infusion. So this effect is of great importance in case of acute management of hypercalcemia, in case of severe increase in calcium level. So in addition to diuretic property, loop diuretics also have direct effect on blood flow through several vascular bloods. The mechanism for this action is not well defined, but furosemide it increases renal blood flow and also causes redistribution of blood flow within renal cortex. And this furosemide it causes a relief from pulmonary congestion, and also it also reduces left ventricular filling pressure in case of congestive heart failure. So, and this occurs before a diuretic response, that is measurable increase in urinary output increases. So, these are the actions produced by loop diuretics. So, thick ascending loop of Henle, sodium potassium 2 chloride transporter. So, sodium reabsorption occurs by this transporter system, and loop diuretics they block this mechanism and they prevent sodium reabsorption. So, any sodium delivery it results in loss of potassium in the collecting duct. So, 25% of filtered sodium is reabsorbed in the loop of inlay. So, loop diuretics what do they cause? They cause loss of sodium and water and hypokalemic metabolic alkalosis and magnesium deficiency, but in hypercalcemia, increased calcium loss. Now, what are the adverse effects with these drugs? They cause hypokalemia, metabolic alkalosis, and hyperuricemia. Hypokalemia manifests as muscle weakness and arrhythmias. So they increase loop diuretics increase delivery of sodium chloride to collecting duct and thus enhance the renal secretion of potassium and hydrogen, causing hypokalemic metabolic acidosis. So this toxicity is a function of magnitude of diuretic effect that can be reversed by potassium replacement. So this occurs because of their diuretic effect, and this can be corrected by administering potassium and also by correcting hypovolemia. Ototoxicity. So they cause dose dependent ototoxicity and which is reversible. And this is most common in patients with a diminished renal function or with in case of patients who are on other concurrent ototoxic agents. For example, in case of aminoglycosides, some antifungal agents, they also cause ototoxic. If patient is on concurrent ototoxic drugs, then they can cause. Then hyperuricemia, they also cause hyperuricemia. Loop diuretics can cause hyperuricemia and precipitate attacks of gout. This is caused by hypovolemia and associated enhancement of uric acid absorption in proximal tubule. This may be avoided by decreasing dose of the diuretic. Then hypomagnesemia. Magnesium deficient occurs. It is a treatment. It is because of its diuretic effect. It can readily reverse by administration of oral magnesium preparation. Then allergic reaction. These like carbonic anhydrase inhibitors. These are also sulfonamide derivatives and sulfur drugs. As you know, they cause allergic reaction. So they cause skin rashes. Then interstitial nephritis. Though it is not common, they may cause eosinophilia, and these are occasional interstitial nephritis. Occasionally, it can cause. So these are once the drug is withdrawn, these reactions are gradually subside. And other agents are, other retoxic adverse effects are they cause severe dehydration. Hyponatremia is less common than with other thiazide because loop agents diminish maximal concentration ability. Patients who increase in water intake in response to hypovolemia induced thirst can become severely hyponatremia with loop diuretics. So loop agents, as I told, they are known for their calciuric effect, but hypercalcemia can occur. Generally, in patients who become severely dehydrated and who have one other previously occurred with cause for, if there is any other cause for hypercalcemia, then such, for example, in case of oral cell carcinoma, so in such condition, they become severely dehydrated. Contraindications, furosemide, it is contraindicated in case of sulfonamide allergic patients, and indiscriminate use is dangerous in case of hepatic cirrhosis and borderline renal failure and in congestive heart failure. Ototoxicity, hyponatremia, and non-steroidal anti-inflammatory drugs, because loop diuretics act at the luminal level. Non-steroidal anti-inflammatory drugs, they prevent its secretion and they blunt natriuresis of these agents. So furosemide 40 mg, 20 mg IV, intravenous, torsemide 20 mg per oral and IV, bumetanide. So plasma of life 2 to 6 hours, bioavailability varies, and in case of torsemide and bumetanide, it is almost 100%. Ethacrynic acid is used only for allergic, self-allergic patients. And therapeutic indications, it is used in case of edema, acute pulmonary and cerebral edema, pregnancy, acute and chronic renal failure, barbiturate poisoning, and salicylate poisoning. So, in case of hyperkalemia, in mild hyperkalemia, after acute management of severe hyperkalemia, loop diuretics can significantly enhance urinary excretion of potassium as a means of reducing total body stores. This response is enhanced by simultaneous sodium chloride and water administration. Acute renal failure, loop agents can increase the rate of urine flow and enhance potassium excretion. In acute renal failure, these drugs may convert allegoric renal failure to non-allegoric failure, which facilitates management of patients. However, loop diuretics do not shorten the duration of renal failure. Then, in case of poisoning, anion overdose like fluoride, bromide, iodide, all are reabsorbed in thick ascending limb. Loop diuretics are therefore useful in treating toxic ingestion of these ions. Saline solution must be administered to replace urinary losses of sodium and to provide chloride to prevent extracellular volume depletion. So Lasix, I think you would have heard this. Lasix tablets, injections are also available. Diamide, bumetanide. These are some of the preparations that are available. Now, clinical scenario: a 65-year-old male presents to the emergency department with severe pneumonia. He is intubated and placed on a ventilator because of worsening hypoxia. He has no history of previous renal disease but becomes increasingly oliguric over the next 2 hours despite adequate fluid resuscitation and vasopressor support. So, do you think administration of loop diuretic in order to improve maintain his urine output would improve his prognosis and reduce the need for continuous veno-venous hemofiltration? So, it's your homework. Next class, I'll ask you the answer for this. You just find out. So, that means whether it is loop diuretics are indicated in case of oliguria, acute renal failure. Thank you.